Osteoarthritis is not a disease of bones. It is a disease of cells that stopped repairing. Long before pain appears, long before X-rays change, the damage is already irreversible. Osteoarthritis is not simple wear and tear. It is a chronic failure of cartilage. Homeostasis, a breakdown of balance between synthesis and degradation. Cartilage is alive, but it has no blood vessels, no nerves, no immune surveillance. When repair fails, damage accumulates silently. Osteoarthritis prefers joints where mechanical load is repetitive, cartilage turnover is slow. Most affected: knee, hip, hand distal interphalangeal joints, cervical and lumbar spine. Not because of weight alone, but because of cellular stress concentration. Healthy articular cartilage consists of chondrocytes, few, highly specialized cells, extracellular matrix rich in type II collagen, aggrecan proteoglycans. Chondrocytes do not divide freely. They maintain matrix through metabolic precision, not renewal. This is their weakness. With aging, mechanical stress, or metabolic insult, chondrocytes shift phenotype. Anabolic signaling decreases. Catabolic pathways activate. Cells stop maintaining matrix and begin digesting it. Early changes: loss of proteoglycan staining, collagen fiber disorganization. Later, chondrocyte clustering, empty lacunae, surface fibrillation. Cartilage becomes brittle, not thinner first, but weaker. Key molecular pathways involved: increased matrix metalloproteinases, MMPs, activation of Adams enzymes, suppression of TGF-beta repair signaling. Inflammation is low-grade, but chronic. This is not arthritis. It is slow enzymatic erosion. Synovial cells react to cartilage debris. They release cytokines, nitric oxide, reactive oxygen species. These diffuse back into cartilage and further poison chondrocytes. A feedback loop forms. Age, chondrocyte senescence, mitochondrial dysfunction. Sex and hormones. Estrogen decline alters cartilage metabolism. Postmenopausal acceleration is real. Smoking impairs cartilage oxygen diffusion, increases oxidative stress. In women, the sharp decline in estrogen during menopause removes a key protective factor for chondrocytes, dramatically accelerating cartilage degradation. Alcohol disrupts chondrocyte lipid metabolism, impairs matrix synthesis. Glucocorticoids suppress chondrocyte proliferation, inhibit collagen synthesis. Nutritional insufficiencies: vitamin D, vitamin C, trace elements. Cartilage cannot compensate for chronic deficits. Unlike bone, no stem cell influx, no vascular repair, limited growth factor access. Once matrix architecture collapses, the blueprint is lost. Repair becomes impossible. The cartilage continues to narrow, losing its ability to cushion the joint. The underlying bone becomes sclerotic, hardening, and losing its shock-absorbing properties. Inflammation sets in within the bone itself, and microfractures appear, signaling structural failure. Finally, the joint architecture collapses, leading to instability, bone spurs, and the irreversible destruction of the joint. Pain is a late symptom, not the disease itself. Osteoarthritis is not inevitable. But once established, it is biologically irreversible. The disease begins in silence, at the level of cells that slowly lose control.